Hi, everyone. Welcome to the 18th webinar of the month in honor of Lymphedema Awareness Month. We're just going to give a couple more seconds as people get connected. It sometimes takes a while for that connection to actually come through. But it is a rainy, wet day here in New York City.
Hi, everyone.
I hope that welcome to the 18th webinar of the month in honor of Lymphedema Awareness Month. And that is what happens when you live stream and forget to turn off that window or close that window. You hear the echo. I learned that the hard way at the conference, and I did not learn my lesson apparently. So anyhow, thanks again for joining us. We're really excited for our talk today. It's with Dr. Jay Granzow. But before I welcome him, I'm going to introduce you to my team just because they're so important and I want you to know who they are. So if my team can come onto the scene, please, that would be great. And here you have Alyssa Fiorito. She is the NLN Garment Program Manager. So for all of you members who are getting complimentary compression garments through one of our amazing sponsors who are, allow me to mention them right now, MediUSA, Essity Jobs, Wear Ease, and Juzo. So thank you so much for all of our, to all of our sponsors. And thank you, Alyssa, for doing all that work. It's a lot. All right, and then next to her, let's see here. Let me just put it on gallery view. Below her, actually, is Veronica Cineres. She is our social media manager. So she pushes out all those things that you see on LinkedIn and Facebook. And then next to her is Christy Blair. She is our project manager. And with her is her lovely daughter, who is like one of the biggest fans of the National Lymphedema Network. And we're so excited to see you. And this is going to be recorded, you know. You're going to be famous. And so Christy is our project manager. Thank you so much for everything that you do. And then we have other team members who weren't able to join us via video. We also have Erin Sokolsky, who is our marketing manager. We also have Jennifer Williams, who is our continuing education manager. And we also have Nicole Ballard, who is our membership manager. So thanks to the entire team. In addition, we have an amazing board of directors, but sometimes they join us and sometimes they don't. And if I do see them pop up, I will introduce them to you as well. At the end of today's talk, we are going to have another giveaway. We're going to give away one of the compression bras courtesy of Prairie Wear. And it's going to either be the Vita bra or the Prima bra. And so if that is something that would interest you, please raise your hands now so that Alyssa will then put you into our wheel of names. Again, thank you to Vanessa who made that suggestion. Vanessa, you've been joining us daily, so thank you so much again for that. And then we'll do that drawing at the end. But right now, we are really excited to welcome Dr. Jay Granzow. Dr. Jay Granzow is a very well-known lymphedema surgeon. He and I go way back. Ever since I joined the leadership team of the National Lymphedema, I've known him, and he has been such a big supporter of the NLN, whether it's with his time, his energy, his talk, sharing his expertise. So Jay, I go by your first name. Thank you so much for being here with us. And we're very excited for your talk. And he's going to be talking about how you would go about choosing a lymphedema surgeon and a lymphedema therapist. And so welcome. And he's from Manhattan Beach, California.
Thanks very much, Jeanette.
Yeah,
appreciate the introduction and the kind words. Certainly, it's been a long road with NLN, and it's been a fantastic experience. I think that just the education and being able to reach out to all the patients that we have and really have people better understand what therapy can accomplish, what surgery can accomplish is extremely important.
Yes, so thank you so much, and we look forward to your talk. The floor is all yours.
All right, fantastic. I'll share my screen here. Is that coming through?
Yes, it is.
Okay, fantastic. So thank you for having me. I founded the Lymphedema Center many years ago because I had gotten into microsurgery and breast cancer reconstruction, and there was a real need for lymphedema surgery that has grown and really gotten better as we've known more about the field. So certainly something that I spend a great amount of time on for lymphedema and taking care of our patients. Pardon, let me see, I'm on the wrong PowerPoint. I apologize about that.
All good, all good.
Yep, let me come here real quickly.
Dr. Jay Granzow speaks internationally. He's been invited to so many, webinars and speaking engagements. It's so easy to, get all these talks confused. So no worries. You know what we can do, Jay?
Oh, here, just what happened is some other talk jumped up in front of the talk that I had. So here, we are all set to go.
Yeah, okay, great.
Apologize about that. That's, let me see. All right, so we'll try again. That was my technical error there. Okay, so here we go. Choosing a lymphedema surgeon and a lymphedema therapist. These we get these questions all the time of how to pick a therapist and how to pick a surgeon, and I'll go through that and go over what we do here. What's most important to me is that we have a really fantastic team. It's not just about me and doing a surgery from the surgery side or from the therapist and just doing the therapy part. It's everyone else who supports us along the way. Amy, Julie, Yvette, our other Julie, Kat, Tao, Linda, and now Wendy, who's joining our team as well, and the rest of our team in the hospitals and in the office. They really add to what we do each day. In addition, this team here, this is my family, and certainly they've given, I've been very fortunate to have the support that they've had to really allow us to do what we do all the time here. Going and starting with the surgeon and the therapist, having a good surgeon and a good therapist and having them work together very closely will give you your best results. You can't do one without the other, in my opinion. Here's a wonderful patient that we've taken care of, came from out of state, and really her success of getting her leg down and also reducing the compression garment needs that she's had is absolutely due to the hard work Julie Soderberg here did with her. She's lymphedema therapist whom I've worked with for a long, long time, as well as the rest of our team again. So being able to achieve these results is very, very important as part of that team effort. And we love getting these follow-ups from our patients back here. So this is her afterwards. And then afterwards again, I actually know that she's had a third baby too afterwards and has been doing well. So we love hearing back from everyone. We sometimes you just see the before and afters and you see, well, this is how some patient, a patient might come after breast cancer. And this is how she might end up afterwards with a 98% reduction in that excess volume and not requiring garment use 8 hours per day. I'll go over how you can achieve that, but it really does come down to choosing the surgeon, choosing the therapist, and really that treatment team that's going to take care of you. Okay, one of the most important starting points is that patients with lymphedema are all not the same. In fact, they're quite different. They're unique. They have very different disease presentations. And everyone requires individual treatment. You can't just do one treatment, one therapy, or one type of surgery, say move a lymph node, and then see if it works and try something else if it doesn't. We want to have an idea of where that patient is in the disease process, how to diagnose them well, and then we can apply the proper treatments, therapy and surgery if needed, to give them those best outcomes in a consistent way. We already know how those patients are we have a very good idea of where those patients are going to end up after our treatments and after our surgeries. So for example, if we start, this is a patient you might call more of a standard patient that someone might see for lymphedema with breast cancer. She's stage 1, early stage. You're going to treat her very different than someone who's a stage 2, patient with stage 2 solid predominant disease. Here in the second patient, that big arm never reduces in size to match the opposite arm. You can't treat that with the lymph node transfer, for example, and expect that arm to get down. In fact, you can't bandage that arm, you can't compress that arm and have that arm come down to the same size as the opposite arm. So, but we have our ways of doing that, and I'll go over that in our talk. Same thing here. This is a patient with a stage 2 leg. This leg never goes down in size to match the opposite untreated side. How's that different? Following, say, treatment for ovarian or endometrial cancer, and someone who comes and has a big leg as a congenital issue, meaning that it came on its own, no cancer treatment, no radiation, no therapy. Is that different, and how is it different, and how do we manage that? Male lymphedema patients. Male lymphedema patients are also very different than female patients. Here's a patient after testicular cancer with lymphedema of the left leg. How do you treat him? And then how do you treat this fellow over here who has lymphedema following obesity? And we'll go over those in the talk as well. And then how do you treat patients who have had maybe a surgery before and not been happy with the result? This is a previous lymph node transfer. This is someone who's had a very outdated type of surgery many, many years ago with a big scar that goes from the inside of the thigh down to the foot, or someone who's had an attempt at liposuction and it didn't work in the right leg. Where did they fit into this story, and how can we treat them well? How can we give them their best results also? So, big picture. Lymphedema therapy is an absolutely key component for a lymphedema treatment system. For me and for our team, we require lymphedema therapy for all patients. It's very important that therapist is a key member of our team, and we rely on the therapy before and then around the time of surgery and then afterwards to achieve those best results. If they're a candidate, we can add the appropriate surgery. There are different types of surgery that are necessary for lymphedema treatment, and matching the surgery to the right patient's condition is absolutely key to providing that best outcome. And again, selection of the type of surgery for each patient is critical. We know that the surgeries do produce significant benefits in the patients, including especially the risk of decreased infections or cellulitis, which are absolutely dangerous to the patient's health. And we know that we can combine these surgeries if done properly or stage them to get the best results. This is something that I was able to put together as a complete treatment system for the first time, and this is many years ago already, and we found that this has been consistently successful over the many years that we've been performing this. So, questions for choosing a lymphedema therapist. We get these questions all the time. What should my therapist have? What kind of qualifications are important? And how do I vet that person? First, I believe it's very important for a lymphedema therapist to be a CLT or a certified lymphedema therapist. And I do think that they need to have completed a full course of at least 135 hours of hands-on training. They do need to possess an unrestricted US professional license. Usually therapists tend to be physical therapists or PT, occupational therapists or OT, maybe massage therapists, but they can be an RN or have other professional degrees as well. There's an additional qualification that's called LANA, or Lymphology Association of North America. And what that does is it gives you to get a LANA certification, they've already vetted those therapists who have that to make sure that they've had these above things. So it's helpful, but not required. But again, that additional qualification confirms those previous trainings that they've had. If you're looking for a lymphedema therapist, you want to find out if they routinely treat lymphedema patients. Therapists could have had their training a long time ago, just been doing, say, PT for orthopedics and not had much in the way of lymphedema experience. And that will be very different from someone who treats lymphedema patients all the time. And then find out approximately how many patients they've treated. They've just more is better. The more experience they have, the better they're going to tend to be able to handle the problems that come their way. And why is that important? Because the therapist really needs to understand the disease progression for lymphedema from initial lymphatic problem to stage 1 to stage 2 disease, and where the therapy fits in at each part of this disease process. And then also have the idea of, well, if the patient wants surgery or if they're a candidate for surgery, how can we integrate that if necessary? Now, lymphedema therapy, again, is an absolutely critical component to a proper lymphedema treatment system. It's a first-line treatment effective for the fluid component in stage 1 and stage 2 lymphedema. So lymphedema is a disorder of the lymphatic system. involves the blockage of lymphatic drainage or the drainage of lymph fluid, in our case from the arm or the leg. And when that fluid at first builds up, it can be reduced down with compression therapy, etc. When that fluid builds up and gets worse, it causes permanent damage to the tissues and can have solids that deposit as well. The therapist needs to know how to treat this. The lymphedema therapy before and after lymphedema surgery is absolutely a key component of successful treatment for that surgery, and that therapy will prevent further progression of the disease. If we're talking surgery, again, that's what I do. Non-surgical therapy must be maximized before a surgery is undertaken or considered. And that therapy can be used as a baseline for how we do with our surgery. Again, I won't get into what the therapy is and how that's performed. There are a month of wonderful lectures by NLN. Suffice it to say that there are many, many different modalities that can make patients better, and they've been very consistently shown to improve patient outcomes. So how powerful is therapy? Well, this is a patient I showed before. This is a patient who has lymphedema following obesity. It's well documented that patients who are very obese can get lymphedema spontaneously. So what do we do for this patient? This is someone who was sent by a local therapist, and Joanne Shinazi, she actually took pictures also before and just after therapy only. So this patient ended up having a fluid predominant issue, was actually stage 1, and with excellent therapy was able to reduce completely, not just in the one leg, but on the other leg as well. So therapy is absolutely powerful in the right patient and in the right hands. Something that I wanted to go over or touch on with respect to that patient as well is, again, morbid obesity itself can cause lymphedema. Patients with a BMI of 50 or less than 50 almost never get lymphedema. And in this study, they had no patients with a BMI of 50 spontaneously getting lymphedema, but those patients with a BMI of over 60 all had lymphedema. So obesity, again, will be a strong, will cause a strong predisposition to getting lymphedema. Now, morbid obesity itself is a significant risk factor for surgery. So patients that are morbidly obese tend not to be candidates for lymphedema surgery. We would like to have their obesity treated first. Why? Because that morbid obesity tremendously increases the risk of having complications from all types of surgery, whether it's lymphedema surgery, orthopedic surgery, cardiac surgery, general surgery. It is less safe to have that surgery performed on someone who is very overweight. In addition, again, there's that predisposition to breaking down or having a decreased lymphatic flow and a worse drainage and predisposition towards lymphedema in very heavy patients. We want to eliminate that so that we can get better outcomes. So patients with morbid obesity tend not to be candidates for me. Okay. Questions for choosing a lymphedema surgeon. So surgery is what I do. I've been doing this since 2005. And so we have a tremendous amount of experience with what goes on with our surgery. And we've really progressed in our treatment methods and our system over the last 15 years. So first thing to ask is the physician board certified in plastic surgery? Why is that important? Plastic surgery is a long training. It's 6 or more years. Nowadays, it's about the hardest residency to get into after med school if you're going directly. So it's going to be very hard to be a competitive applicant if you're not in the top 5 or even top 2% of your medical school class. Why is board certification in plastic surgery important? And you can be board eligible at first if you've only been out the first couple of years. That's because the hospital will not give you privileges to perform inpatient surgeries for lymphedema type surgeries if you're not a plastic surgeon. So if you're a dermatologist, they're not going to allow you to perform liposuction, which shouldn't be performed for lymphedema anyway, but even suction assisted lipectomy or other procedures in the hospital. And the hospital is a very important tool to have to treat lymphedema patients. What's also important is that doctor not just have a plastic surgery training, but a specialized microsurgery fellowship afterwards. A fellowship is additional training full-time after their initial residency, which is their baseline training. That's if they want to be able to do vascularized lymph node surgery or LVA surgery. Those are microsurgeries, and to do those properly, you need that extra experience, in my opinion. In addition, I think it's very important to ask how many surgeries or how many lymphedema surgeries that doctor has personally performed. It's very different if someone has been assisting surgeries during the residency compared to when they're doing surgeries on their own afterwards. Having the independent experience and seeing how those patients do is absolutely key. And I think that's a very valid question to ask the surgeon. The VONT and LVA types of microsurgery and super microsurgery procedures have an extremely steep learning curve. LVAs are the steepest one of all. And I can tell you that my procedures for both of those have, even in the last 5 years, will be improved. And having the experience of doing more and more patients makes you better with those surgeries. The surgeon should be routinely performing lymphedema surgeries. So performing 1 or 2 a year is going to be very different, and I do not think as good as someone who performs them every week, because they won't have the same type of experience with that. And then more cases is better, meaning that the more cases that you've performed, the better your outcomes tend to be in that field. Another and absolutely key point is is that surgeon part of an integrated lymphedema system and lymphedema center, and who is on that team? For us, we have a center. I have 2 lymphedema therapists. I have a PA who is also trained as a CLT, and then we have the whole assistants and back office staff to help with the insurance. Everyone works as a coordinated whole to provide those patients that optimal experience. When they come to us and see us in the office, they expect to spend about a half a day with us. So the patient will see the therapist, then they'll see the physician assistant and CLT as well. And then I'll see the patient and spend usually between 30 and 60 minutes going over the patient's specific unique condition. Again, each patient is unique, and having them understand where they are in that disease process and what we can do to help. I'd be more careful. You want to go to someone who is really interested in taking care of you, not just wants to come in and out of the door and maybe prescribe a surgery. And that applies not to lymphedema surgery by itself, but to any type of surgery that you're considering having. And that's what I mean by the surgeon team should have a patient-centered approach. That's absolutely key. Our office focuses on taking care of the patient as our utmost goal and responsibility. Okay, for me, my first lymphedema surgery was in 2005, where I was visiting and working with Dr. Kashima in Japan, and I've performed hundreds of lymphedema surgeries since that time. I've also traveled and visited in the operating room all over the world, whether here it's Taiwan or France or Sweden, with some of the world's top surgeons, and whom I very much respect, to be able to bring together those skills and to provide the patients the absolutely best outcomes. Okay, so lymphedema surgery. What can lymphedema surgery itself accomplish? It can produce definitive results and achieve significant improvements in symptoms and quality of life. From our own data, our expectation is that the patient's arm or leg, if it's larger than the other side, will get down to match approximately the size of the uninvolved side. That's what we expect. And our average results are an 86 to 111% volume reduction, a reduction of volume excess. A number greater than 100% means that that affected side actually ends up smaller than the unaffected side. And we see that quite frequently as well. So that's our average expectation. My average expectation is not that 100% of patients get better. We already expect that to happen, but that the reduction is also on the order of 86 to 111%. What's absolutely critical for us is that we are reducing the infection rate for the patients from 58% to 15% in all procedures on average. And we significantly improve the effectiveness of the lymphedema therapy. and we can achieve significant reductions in the amount of compression garments needed to keep that patient's arm or leg under control. And we've published these in previous studies in major medical journals as well. So I'll go over the types of surgeries in detail. And again, and I'll try and answer the questions that I get quite commonly or even recently as I go along the way. So for the solid component, meaning if someone has a stage 2 advanced disease, I perform SAPL surgery or suction-assisted protein lipectomy. What is SAPL surgery? This is where I aspirate or suck out the extra permanent solids that are present in late stage disease. So that lymphatic fluid is present, causes inflammation, causes damage to the tissues, and permanent fats or proteins set in so that arm or leg does not go down to match the opposite unaffected side. This lymphatic drainage system has previously already sustained tremendous damage. And what my goal is to downstage those patients from a solid problem to back down to a fluid only problem. When we aspirate this, the skin looks floppy at first in the operating room because we typically reduce the volume by thousands of cc's of volume. That skin actually shrinks down on its own in very short order, on the order of usually a few weeks. We don't have to cut that skin out in almost all the cases. So 99% of the time, we do not have to remove that excess skin. It shrinks down on its own if we're using our protocol to post-operatively get that swelling down. What's also important is that SAPL surgery is not cosmetic liposuction. We've seen many, many times where patients have come and been treated by so-called liposuction, but the post-operative protocol is different. The procedure itself is different. Yesterday, I took care of a wonderful patient who had second stage lymphedema problem, and the cannula and the machine I use are absolutely different and certainly put me to work. Using the smaller cannulas that are used for, say, cosmetic liposuction are absolutely ineffective, and the postoperative protocol for a cosmetic one is absolutely ineffective. So someone who's just doing cosmetic liposuction is not going to be able to take care of a lymphedema patient in the same way. What are our results and what are our numbers? So what can we achieve consistently? These are our average numbers. These aren't just the best numbers, these are average numbers for us. So the affected arm or the affected leg. So for an affected arm, they have almost a 1 liter volume excess, or 929 or 878 cc's. At surgery, we got out about 929 cc's. In a leg, we have almost 4,000 cc's, and the volume reductions at 4 months and 1 year for an arm is 111%, meaning that that arm, on average, ends up smaller than the unaffected side. So the treated arm, in our experience, ends up smaller on average than the opposite side. That's our typical expectation. The leg will very much approach that size. And again, we're having the patients get back to shopping in the normal clothing section, not have to take in pants, not have to alter clothing, being able to fit into boots, especially when they live in colder states. And that's what we see routinely in our office. And by the way, to put in perspective, 2,000 cc's is what you find in a 2 liter soda bottle that you buy at the convenience store. So it's quite a lot. Again, during my early part of my practice, I went and I visited Dr. Borshin, where we were exposed to his technique, and we've since been able to adjust it to fit United States model here. He's an absolutely wonderful individual, and he really is the pioneer in the SAPL type technique to reduce those volumes consistently. And he has wonderful data. It's very consistent, and is really the person to thank for having providing the basis for us for this technique. Again, here we are in the operating room and treating a wonderful patient with very consistent results as well. Here's a picture of what we can accomplish during a SAPL surgery. So this is, again, I'm using a tourniquet. This is an orthopedic device to reduce bleeding and swelling afterwards. It's very standard. And what we can see here is that I'm using special passes of that cannula to reduce or eliminate the damage that happens to a lymphatic system. So the surgery is safe. The lymphatics are not damaged with our surgery. And I can prove that. We image the patients before surgery and after surgery with indocyanine green, and we find that those channels are unharmed. Here, that you have to do that in a special way, pass the cannula in a special direction, but it's very consistent. So here the patient goes from a preoperative diameter of the leg of approximately where you see in the red arrow. And this is how small she's going to get after surgery. So you can see that the difference in those diameters is quite a lot. I've done the outside portion of her upper leg, and I'll come back and finish off the inside portion and extend that up to the thigh to achieve our consistent results. Again, therapy integration is absolutely critical. So the therapist and the surgeon need to work hand in hand. It's very important to know and to ask that surgeon who is on their team. The therapist is critical. I think that at least for surgeons tend to focus a lot on the technique only and not on the therapy part. And I find that the therapy part is absolutely indispensable. Here, Julie is in the operating room performing bandaging for our patients to get that patient that very consistent best result that we can. These are a standard amount of bandages that any therapist will understand from the bandaging. This is not ACE wraps. These are very different. They're lymphedema bandages. ACE wraps will not work. I feel that they can be, they can make the patients worse. And most therapists are really get uncomfortable thinking about someone being ACE wrapped in the operating room. All right, SAPL surgery. One question we have is, well, why do you need compression after SAPL surgery? Well, patients who have advanced lymphedema disease need compression before surgery already. They have a tremendously impacted and damaged lymphatic system, and the SAPL surgery does not increase the amount of therapy that they need. That patient, again, therapy needs to be integrated with the lymphedema treatment program and with lymphedema surgery, and that patient needs to be in full therapy prior to consideration for surgery. So typically they'll need compression most of the time, up to probably 23 hours a day prior to surgery. And then after surgery, that really doesn't change. It decreases some actually, and it improves some, but we're just reducing that volume. We're getting that inflammation down. We're improving that outcome so that the compression becomes easier. The leg is easier to take care of, leg or arm. And the compliance after surgery with the garments is extremely high. In fact, I won't do your surgery if you're not going to be compliant with that garment afterwards. Now, after SAPL surgery healing is complete, we can then perform additional staged surgeries such as LVA or VLNT, which are microsurgery procedures to reduce that need for the compression further afterwards. And we've described that many times as well. Now, SAPL surgery in my hands rarely requires skin excision. I've recently gotten quite a number of questions on this topic as to why sometimes skin seems to be excised by certain surgeons. I very much respect my surgical colleagues, and people have different approaches. In my hands, I just haven't found it to be necessary. With our postoperative protocol and the proper therapy, the skin retracts on its own. It shrinks down due to the inflammation. And so in 99% of the cases, there is no surgery required. And the reason is I do not want to have possible wound healing issues or other issues in healing of that long surgical scar. And I would like to not damage any lymphatics that are running underneath that skin in that area, especially on the inside of the leg or the inside of the arm. I feel that those are areas that I will often potentially use later for LVA surgery to further decrease the need for compression. And I don't want to have operated in that area previously because I feel that will reduce the result. So again, that's something that works in my hands in this way. Here's some examples. So this is before SAPL surgery and afterwards, but no skin needs to be resected. It shrinks down on its own. Again, here's a patient with bilateral leg lymphedema. And again, when we perform our system, these are consistent results that we expect to achieve. And again, no skin excision is required. That skin shrinks down on its own, and essentially in almost all cases. Now, what about that 1% of patients that I mentioned that do require excision? That only happens if that skin is so severely damaged that it no longer has proper tissue planes underneath, meaning that it has scars straight down to the fascia, and it has significant skin overhang, especially in the lower leg, such as this patient. We'll go over her case later. So this is a rare case, that 1%, where she might require that excision. If you don't have this overhang, I think it'd be very unlikely in my hands to require the excision. Now, compression does become easier after sample surgery. Again, we're not increasing the need for compression afterwards. Just like this party balloon, it's always hard to inflate that party balloon when it's small at first, but once you get that balloon going and stretched out, it's much easier to inflate. That means that the compression, again, in a similar way, due to physics for the balloon, is in the smaller circumference, that compression is more effective. In the bigger circumference, it's less effective. That's why it's easier to blow up a bigger balloon. After surgery, the leg or arm goes down in size, the compression becomes more effective, and it's easier to take care of that arm or leg after sample surgery. Here are a couple case studies. This is a patient with chronic lymphedema for 19 years. She had solid predominant issue where that arm does not go down to match the other arm ever. She had infections that were so frequent that she required antibiotics by mouth every day to prevent those infections from taking over her life. She had 898 cc's of volume excess. And again, 6 months after sample surgery, we're able to consistently get the size of her arm down. Again, she is wearing compression afterwards, and we can see this from her tan line because she lives in a very sunny area. And again, these results are permanent. If the patients continue on with the proper postoperative regimen or protocol, which is to graduate down to that garment, then this does not ever come back. And we have had 0 recurrences for patients who have maintained the compression consistently afterwards. Here's a patient with congenital chronic lymphedema for 46 years. She's the one with the scar that in the previous surgery that went down the inside of the leg from the thigh to the foot. And this procedure was done 25 years prior. This is not a procedure I perform. This is not a procedure I've really seen almost ever because it's really something that is not performed anymore. She, again, also had multiple infections or attacks of cellulitis, and she had almost 5,000 cc's of volume excess. So again, with sample surgery, consistently, even in a patient with that tremendous scarring, we're able to get that volume down tremendously at 6 months. So at 6 months, essentially 100% of our patients are improving already by that time, and that improvement continues. Now in this patient, what was very interesting is once she started getting down in volume, she's able to move much better. And she's getting back on an exercise bike, she feels better, and she starts to get back into better shape, feel better, and 9 months she improves not only on the affected side, but in the opposite side. And at 21 months after surgery, she's even better on both sides. And again, no skin excision is needed. That skin retracts on its own. Here's a picture that she sent me from before and after wearing the same clothes so that I could show this to other patients. Here's that patient that we talked about previously or showed previously with a congenital issue. SAPL works also for patients with congenital lymphedema. This is lymphedema that does not happen after cancer. And so this is a before and then a after view. And again, we didn't have to excise skin because the skin retracts on its own. And this is the patient for the first time shopping and getting back into jeans or boots since she was a young teenager. Again, SAPL surgery is not cosmetic liposuction. It's a very, very different procedure. The workup is different. The procedure is different. The pre and post-operative care are different. And integrated lymphedema therapy is essential both before and afterwards. The machine I use is different. At least the equipment that I use is different. And patients with lymphedema will not respond properly to post-operative cosmetic liposuction protocols, even if the thick lymphedema material can be removed. Why do I say that? Well, lymphedema solids are much thicker, more dense, and fibrotic and harder to remove than cosmetic fat. Using a normal cannula will usually result in an incomplete reduction or removal of that tissue with a continued inflammation afterwards. This is how cosmetic liposuction fat looks after surgery. It's a nice creamy yellowish consistency. And this is what might come out of a patient with lymphedema. This looks more like curdled milk. It's very, very hard to get out. Typically it takes 4 hours of surgery as an inpatient, in an inpatient setting in my hands to treat one arm or one leg for the patient. And again, the volumes we're removing can be quite high, on the orders of thousands of cc's, to be able to get that patient's arm or leg down. Here, it's a leg, definitely, consistently. Again, this is a patient, and this is that other patient that I showed before. She was actually treated with liposuction before. This is after that liposuction treatment, and it didn't work. Using our method, sample surgery, we were able to reduce that leg down, and so such that 2 months after surgery, her leg looks like this already. And again, how much volume was removed? In this case, we removed 8,430 cc's of material. That's more volume than is found in 4 2-liter soda bottles. And again, here, this is one of the very, very rare cases where we did have to remove the overhanging skin. Why? Because that skin was so badly diseased that there was no plane or separation from that skin all the way deep, or several centimeters, even several inches deep, down to the layer above the muscle. That was one continuous layer. We removed that in the areas that was diseased. This is how she looked on the operating room table, but with proper bandaging, we maintained that. And these are photos that she sent us again, and this is her before, and this is her afterwards. In my hands, I can equally well treat patients with congenital lymphedema of the legs as secondary lymphedema using sample surgery. Again, sample surgery is safe. The lymphatics are not damaged before and after surgery. This is a pre-op imaging that we've had, and this is afterwards. Those lines on the surface are just pen marks where we are marking out the course of those lymphatic channels, but we can see the before and afters do not change. And in many cases, they actually improved because we've improved that inflammation and decreased that inflammatory tissue. This is a patient where the lymphatic drainage system is in a much worse shape than the previous patient already on the left, and she gets some improvement at least towards the right, but it's certainly no worse. And this has been shown back to 1998. In fact, sample surgery is one of the safest surgeries that we do of all the plastic surgery procedures. I've never had a major complication where I've had to take a patient back to the operating room. Overall, the complication profile is very low. The improvements are dramatic and life-changing. One note is that male patients tend to have a more difficult recovery than female patients for a number of technical reasons, but I'll go over, here's an example. This is a patient with a history of testicular cancer, treated with orchiectomy, chemotherapy, radical lymph node dissection. He had significant functional impairments with a volume excess of 4,747 cc's. Before surgery and after surgery, we achieved an 89% reduction. What does 89% reduction look like? This is him. The recovery in this patient will be slower. It'll be more difficult, but overall, we can get them to the same place as our female patients. It just tends to be longer, and we have to have even more in-depth therapy. Again, no skin excision was needed. I'll touch on the microsurgeries as well. First, I'll go over the vascularized lymph node transfer surgery. Again, this is for removing the fluids. You can't remove solids with the VLNT surgery. This is where we use a high-power specialized operating microscope in the operating room using very fine instruments to be able to accomplish our procedures. The sutures for these types of microsurgery are extremely tiny. This is a slide I made many years ago with Dr. Koshima in Japan. This is the size of a standard ballpoint pen. There's a fine human hair for reference. That's my hair. And then there's a microsurgery needle for a lymph node transfer type of surgery. And then there's a even smaller needle for a lymphedema or LVA type of surgery. For vascularized lymph node transfer, we transfer lymph nodes from one area of the body to another part with an artery and a vein that provide the circulation. So in the middle here, you can see there's an artery and a vein, which are the red and the blue, connected to the lymphatic inflows and outflows, which are the green, which is where the arrows are found. We can perform this from the groin area up to the axilla for patients, say, with lymphedema after breast cancer. What's key is that we avoid those lymph nodes and lymphatics that are draining the leg to avoid lymphedema. And I'll come back to that in a minute. Same thing, we can take it from the torso, not the armpit, but the torso, and transfer it down to the leg to treat someone with leg lymphedema. Again, preserving those lymphatics and those lymph nodes that are up in the armpit or axilla and that are draining the arm. We can even perform VLNT surgery together with breast reconstruction, such as a DIEP flap, for a combined procedure to improve that patient's outcome. So what are possible mechanisms of action for why VLNT surgeries work? Well, say we have a patient with a breast cancer lymphedema. They have tremendous scarring in that axilla. First thing we do is we remove that scar, and we replace that scar with the healthy tissue that we've transferred containing the lymph nodes. As healing occurs, the lymph nodes cause the adjacent lymphatics to heal and connect back into those lymphatics. And that's been shown with studies in the medical literature. The arteries and veins also connect back to the arteries and veins. We manually reconnect the big artery and vein, but additional arteries and veins flow in and provide additional vascularization into that flap for additional healing. And that lymph node can then directly transfer the lymphatic fluid into the adjacent vein. I think it's very important that lymph nodes are transferred with the flap. I've had questions also as to why do we not perform, for example, just a lymph vessel transfer as opposed to a lymph vessel with lymph node transfer. And in my opinion, again, I respect my colleagues' opinions, but in my opinion, I feel that the lymph node is extremely important because it will provide for a better result. It will allow the lymphatics to connect better, and you need that lymph node to be able to connect into that vein to better drain the lymph fluid from that during that lymph node transfer. So the lymph nodes normally process lymphatic fluid and drain directly into the vein. Here in this schematic, we can see the entry points of the lymph with the arrows that are pointing inside. That fluid is then processed, and a lot of that lymphatic fluid is then processed and goes into the vein, into the venous system where it belongs, and it goes out. Some of the excess goes out and some outflow as well, which is the outflow tract. I think you lose that if you don't transfer lymph nodes with the lymph node flap. So again, that's what works in my hands, and we've been doing this very successfully for many, many years. I think that not including the lymph node with the flap will reduce the amount of lymphatic drainage that is present. And these are some mechanisms that have been studied in the medical literature. Again, when we move, these authors found that when they moved flaps, which means an amount of soft tissue, and they moved it from one part of the body to another part of the body with lymph nodes, and they put an ICG or icy green tracer in there, they found that that tracer went down into the vein, into the flap, and into the vein. But if those flaps did not contain lymph nodes and they placed ICG tracer, then that tracer did not go through the flap and into the vein. So again, I feel the lymph nodes are quite important. Here's another paper. Again, I took this exact title for this slide. The lymph node transplantation results in spontaneous lymphatic reconnection and restoration of lymphatic flow. Here's an interesting video that came from another paper from these authors. This is an author who placed the lymph node flap down in the ankle, and some surgeons, again, it's not wrong to do this. I personally choose not to do this for a number of technical reasons, but they can place it on the back of the wrist or the foot. It'll tend to result in this bulge as a flap. And this one very well illustrates why I think lymph nodes are important to be transferred. We can see that small injections of indocyanine green dye here actually drain towards the flap that contains the lymph node rather than towards the center of the body and up towards the proximal or the central portion of the leg. So we can see that tracer is going towards the flap with the lymph node, into the flap, and then will go into the vein. So I believe those lymph nodes are very effective when they're transferred properly. Again, here's another image from the same center as to how lymph node transfer might look to the ankle. Again, I personally don't perform it down here. I feel that I can achieve similar or better results if I transfer it up into the thigh or more hidden areas as well. But again, that's not wrong, and I very much respect my colleagues' approaches. I just find that I have, in my hands, the results are different if I move the lymph nodes into different and more hidden areas. Here's one of my patients, and this is where I'm actually imaging the lymph node flap with some indocyanine green to make sure that the lymph nodes are in the flap that I'm moving. So we can see the injections in the skin on the left, and then inside there's the flap, and I'm moving them with a forceps, and I can see that that lymph node glows inside of there. I then harvest that with an artery and a vein, and I reconnect it, and I take it from an area, again, of lymph node excess, and I move it to an area where those lymph nodes are deficient. This is a video that has been very popular as well with many of the patients, so I'll show it here. This is how we actually connect an artery and a vein when we're performing lymph node transfer or other types of free flap surgeries. This is actually a DIEP flap breast reconstruction, but the procedure is essentially the same for a lymph node transfer to connect the artery and the vein. The artery is a large vessel in the back, and here the vein is being spiked onto this very special implant called a microvascular coupler to keep that vein open. Why is this important? Because the vein is a low pressure system. The vein walls are very thin and very pliable, and this prevents those vein edges from flopping shut and having clots. It dramatically reduces the complication rate in a venous reconstruction or venous anastomosis. And here we've sped this up. And this is performed on one side. On the flap side, that was the chest vessel side. This is the flap side now. And again, we're spiking this together on here to be able to connect that vein quickly and easily in the operating room and to provide that vastly improved result. Most people nowadays use this device. And again, that little ring stays in. There are many small items that will stay in the patient. For example, those little, they look like metal pieces in the back. Those are called vascular clips, and they are standard items that are placed to control bleeding and control those vessels in a very, very controlled way in many, many types of surgeries. They tend to be made out of titanium, so they don't go off in the metal detector. And they're used routinely in almost all type of procedures, say as thyroid surgery, endocrine surgery, or any other type of procedure. So here there's an artery. This artery is being divided. We can't use that coupler device for the artery because the artery walls are too stiff. So we sew those by hand. So here the artery length is being matched up with the flap. We trim the artery down to size. And we sew that artery back by hand using that microsurgical suture. There's a special type of double clamp that in this case is being employed to hold the vessel in place. And then I'll go ahead and speed this up here again. It'll speed up in just a moment. And again, we'll very, very carefully place those sutures, tie them down individually as needed. When we move that clamp, oh, sorry, this is the back side, so we need to do both sides. And again, this is standard for microsurgery here. Those little squares on that green background are 1 millimeter to give a reference frame of how small the vessel is. Clamp is being removed. And we remove another clamp so that we can see the blood flows back through the artery. The artery starts to pulse. We allow things to clean up, and we can see the artery pulsing here. And we can see the blood return back through the vein with our strip test. So we push the blood out of the vein on one side and it flows back from the flap. Okay, what can vascularized lymph node transfer accomplish? We can accomplish a tremendous amount. This is a patient who came and has a stage 1 lymphedema. I was able to perform a vascularized lymph node transfer. And because we caught her early enough, we were able to completely reduce the symptoms and remove the symptoms, thus that she does not require garments every day. And she is essentially almost lymphedema symptom free. Now, I know that this has been called a cure, and we have seen this in multiple patients, but I personally feel that calling it a cure is inaccurate. So I feel that this is a patient who's been completely treated and the symptoms have completely resolved, just like maybe if you had a ACL tear in your knee and a tendon tear and you had a repair of that tendon. That's not a cure of the knee, it's a repaired knee, and you still need to be careful of that knee or your arm here lifelong. But again, this is a patient where no garments required after surgery, where she did have significant lymphedema swelling before surgery. You can see in her right hand, the one opposite the watch here, and this is how she looks afterwards. Again, the lymph node is transferred up into the armpit, not onto the wrist, and I think we can still achieve tremendous results with that transfer. These results are stable, lifelong. In my experience, this is a patient who I took care of over 10 years ago. She was an LAPD police officer. Her father was a police officer, and she needed to be able to qualify and get back onto the police force. She had tremendous lymphedema swelling. We did the lymph node transfer and took that swelling away completely, and she was able to go back to work full time. Again, the garment requirement before and after LVA and VONT goes down tremendously. So most patients before the LVA and VONT surgery require garment use more than 8 hours a day, and most then do not require it afterwards. In this case, the results are that most patients improve the amount of garment that reduce the amount of garment use that they need before and after surgery dramatically. Now, safety. This is a question, again, we also get asked a lot, and rightfully so, is how do you protect those lymphatics that are required in the area where you want to borrow a lymph node transfer? Again, we've had a fantastic safety record. We've never had an issue. And that's because I borrowed the lymphatics that are very out and peripheral. Here would be in the groin area, and those don't drain the leg. These do. I can map and image these out. This is a CT scan with a lymphoscintigraphy, and the lymph nodes that are glowing are the ones that drain the leg. So we want to borrow lymph nodes that don't glow and don't drain the leg. We want to borrow from there, not from here. And we can do this consistently in the operating room. There's a special probe, and here I'm using that probe that I can use to map out those lymph nodes. It can happen. It's very unlikely, but I can find that the lymph nodes are in that whole area are draining that leg or draining on that arm, in which case I just leave those and we go to LVAs only for that patient. Here's a tracer of where the lymph nodes are that I don't want to take. And here's the lymph node flap with no counts in it, showing that it is safe to take that. Finally, I'll touch on LVA surgery briefly. LVA surgeries are direct connections from the actual microscopic lymphatics back into the venous system to allow direct drainage of the lymph from that lymphatic system and that area of congestion back into the venous system where it belongs. These lymphatic vessels are typically 0.1 to 0.9 millimeters in diameter. So thus it's called super microsurgery, or surgery less than 1 millimeter, to allow us to perform these connections. We make transverse incisions across so that we can find as many vessels as possible and connect them to the veins. And we connect them by hand. We sew with this very, very tiny suture. We can see the lymphatic vessels coming from above. It has some blue dye in it. And I've connected it into the side of this vein. And you can see that the dye is flowing from that lymphatic vessel directly into that vein. And my first experience with lymphatic surgery, again, was in Japan in 2005. And Dr. Yoshima, this is us just a couple of years ago at a conference, and we keep up. Again, there are a lot of other well-known surgeons in this picture too. I very much respect all my colleagues. I know that different colleagues have different approaches. I think they're very valid, and but I'll have my reasons for doing them my way, and I'm going over the things that work for me in the operating room consistently. Again, I'm very honored to be part of a really wonderful community of surgeons and really talented individuals who are making patients better all the time. So here I use indocyanine green imaging to map out those lymphatics and where I can place my incisions so that I can find that lymphatic and I can connect it into that little venule. So here I am in the operating room. I'm using the specialized SPY system here. In this case, it's the indocyanine green imaging, mapping out the lymphatics, and then I can come and I can make those connections. So there's a little lymphatic on the left that's connecting to a vein. That big stick there is for reference. It's a 6-0 suture, which is smaller than a suture that you would, for example, see on someone when they had their hand sutured in the emergency room. On the right there, there's a lymphedema surgery needle and suture. Here's a 1 centimeter and then 1 millimeter ruler, just to give a size reference. Here's a video, and I've attached a lymphatic from the bottom of the screen up into the vein here. Here I then remove the clamp from the lymphatic, and you can see it fill, and this will then fill the vein right there. So we can see that there's a tremendous amount of lymph that can transfer from the lymphatic to the vein, such that even if we empty the vein with a forceps, it fills right back up with the tremendous pressure of that lymphatic that is being, or that lymph from the lymphatic that is pushing back into that system. What are our results with LVAs? Again, this is a patient before surgery. This is a patient 1 week after surgery and 55 months after surgery. So these are also permanent results. We find that I'm not looking for large volume differences for LVA surgeries. I've already achieved that with the good therapy or with my SAPL surgery. We're trying to maintain and keep that patient down to have less compression or conservative therapy that she needs afterwards. In this case, what you don't see is that the patient went from 2 hours a day, every day, so approximately almost 60 hours of self-care, lots of garment use, compression, pump use, down to just approximately on the order of 4 hours per month of self-care, plus garment use, which is less. She's able to hike during the day or be able to get out on the boat without any compression and catch up in the evening and inside the home. Again, matching that patient's condition with the proper surgery is extremely important. Here's a patient who did not have a volume improvement following previous VLNT and LVA surgery. She had a chronic solid predominant lymphedema. And again, she has those tremendous excess solids that are present that can't be removed with the microsurgery. So here, VLNT surgery was performed up above and an LVA below, but no reduction in volume was achieved. She had some reduction in symptoms and some improvement because there is some fluid that can be treated with that. So we performed a SAPL surgery, removed 5,700 cc's of volume, and she had an 82% excess volume reduction at 1 year. And this is what an 82% volume reduction looks like. So even after other surgeries, we can still catch up, but it does remove my options for subsequent microsurgery sites to further reduce that volume at a later, or at least the compression garment use at a later date. Here's a patient with an arm. She had a SAPL surgery as a first stage and a VLNT as a second stage. Again, she's a hard patient. She had chronic stage 2 lymphedema, very large arm. That arm never went down in size from this one here, and she needs a daytime and nighttime garment before surgery. Again, this is what we expect is a consistent result after SAPL surgery, phase 1. Again, she's wearing that compression garment following surgery because she lives in a sunny area, but her arm volume has essentially normalized. Afterwards, performing a lymph node transfer from the groin to the armpit or axilla, and this is her result. And I'll put it in perspective here with the pre-op result, but here in the post-op result, she's able to be out of the garment for 8 to 12 hours every day. That means she can play golf. She can go outside. She does not have to wear the garment in public. And again, that tan line is now gone. That's how she looks because the lymph node transfer went up into the armpit or the axilla. And we find this as a consistent result. So here's a patient with 99% volume excess reduction from before and after surgery and no garment 8 hours per day. This is a patient with a volume reduction of 95% and no garment 12 hours per day. This is a leg patient, and after surgery plus VLNT and LVA second phase surgeries, she had a volume reduction of 109%, meaning that that affected leg is actually slightly smaller than the less affected leg. And she tremendously decreased the amount of garment use and symptoms after surgery. And this is something she sent us previously. I actually spoke to the patient this week on the phone for other reasons, and she's really doing fantastic. She's doing great with her legs, and she's even back in the shoes that she wasn't able to fit after her lymphedema, but she did fit for her lymphedema. And we're really thrilled to see that result. We've published this in the medical literature as well, in a major medical journal. One last thing that I'll touch on is insurance coverage. Insurance coverage, as it is right now for lymphedema, is a very complicated issue. We here, the only procedure that our HMO will pay for, we feel like this all the time. The lymphedema surgery coverage is always a problem. We always work with the patients, and I have a whole team of individuals that work very closely with the insurance companies to get the coverage, and we do very well with the coverage for our patients that they can get their surgery and their treatment taken care of. This involves usually appeals on some sort of level, and these can be in the dozens or hundreds of pages sometimes. Here's one binder that we had for that. So we work with the patients very closely to get those surgeries covered. Overall, the take-home message is experienced lymphedema surgeons and therapists can provide tremendous improvements if you get the right surgeon, right therapist who knows how to treat the patient and adapt the proper lymphedema therapy or surgery to that patient. I feel strongly that the surgery should be performed as part of an integrated system by a team of individuals that work closely together consistently. The type of surgery that's chosen is critical. We know surgery is not a magic bullet because, again, that therapist is absolutely key to the success of that patient's outcome. And we want the patients to maintain that relationship with their home therapist whenever possible for the best overall result. Thanks very much.
Thank you so much, Jay. I have to admit that watching the surgery, it was mesmerizing. Like, I could watch the whole surgery, and that is a discussion that you and I will have offline. We're going to offer, I'm going to see if you'd be willing to videotape a whole surgery from beginning to end and open it to our members to watch. But that's for another day.
Well, we have, it's hard to see in the surgeries. And so when you watch a surgery, you wouldn't really see as much in many of these. We've actually, those surgery, some of those pictures are actually through the old microscope. The new one has a better video camera, and we've been busy taking some really good videos as well so that we can really tune you in on the key parts of that. I think some people watching lymphedema surgery would say it's sort of like watching grass grow if I'm picking at the little lymphatic vessels all day. So I'll certainly spare you those things and zoom in on the highlights of what's important.
Perhaps. I think it depends on who you're talking to, but there are some lymphomaniacs out there, such as myself, that would not view it that way. And it's a little bit more exciting to us. But so thank you. So what we're going to do now is definitely welcome questions. We have several questions, but an important thing that I always forget to do in the beginning, and I always remember at the end, is that our disclaimer is such that the views and opinions of Dr. Granzow, even though we absolutely love him and value everything that he's shared, it is not necessarily the opinion or position of the National Lymphedema Network. And the views and opinions expressed were those of his own. However, there is one that is of the National Lymphedema Network, And that was when he was talking about the therapist and choosing a therapist. We do have a position paper available currently on the therapist training. And that first line on his slide was taken from our position paper. And there are two things that I'd like to highlight in that. It is 135 hours of lymphedema training, hands-on. So the two operative words are lymphedema and lymphedema focused and hands-on. So I'd like to take a moment just to reiterate that we still stand by that position paper, even if it's from 2012, I think that one was. And you know, we are working actively on putting together the committees to update all of our position papers this year. And we hope to have them in time for the conference to have its debut. But, you know, it's going to be an ambitious task, but I think that we can do it. And Dr. Granzow is, you know, he doesn't even know it yet, but he's on the surgery committee. So
I've been part of the committees with NLN for over, I think, almost 10 years now. So I'm definitely very attuned, and I'm very happy to help. I think absolutely, like Jeanette says, the hands-on part is absolutely critical. You can't just take an online course. You can't just take, it's like fellowship for surgery. You have to go and do the residency. You got to go do and work with someone who really knows what they're doing and has a consistent system, and then get out there and be able to do things on your own consistently also. So absolutely, it is very important that otherwise there's too much to know with lymphedema therapy, even for a 135-hour course. That's just a good start, right?
Absolutely. That is the bare minimum. And I will tell you that having been faculty for a former school, you know, there were lots of therapists that I was just thinking, I'm not so sure if I should pass you, but I know that you have so much pressure at work. And if I don't pass you, you know, there's going to be like a lot of trouble for you professionally. And, you know, but, you know, you had to think like, does this therapist at least have safety? Like, will the patient be, will this therapist be safe with patients, and will they be able to grow? You have to have that ability to project the professional growth trajectory. And, you know, but again, that has always been the absolute minimum. Anything less than that, it's really hard to say that, you know, a therapist coming out of such a training would be well equipped to safely treat patients with lymphedema. And I'll tell you that most certifications don't even have a comprehensive offering, in the sense that you leave a training knowing how to treat a limb. You don't even really know how to treat abdominal lymphedema, genital lymphedema, head and neck lymphedema, breast chest lymphedema, scarring, all the complications that can come with it. So again, we must highlight 135 hours of hands-on lymphedema training is the bare minimum. So thank you for that. And then let's see, what else is there? So, you know, Jay, I have a couple of questions for myself. So, you know, you recommended a couple of questions to ask of a lymphedema surgeon. Now, are most surgeons receptive to such questions?
It depends. And that's an excellent question, because surgeons are going to be surgeons and you're going to have different characters. If someone's not receptive, then they're not someone you want to have as your surgeon. I would never go to a surgeon that's not receptive to questions. And it doesn't matter if you're having lymphedema surgery or surgery on your toe or heart surgery. It's fine to have another opinion as well. And I welcome patients, and I want them to ask the hard questions. I want them to ask, what are the problems that you can potentially get, or why do you do it your way? What are your reasons? Because I'm incredibly compulsive with what I do. I mean, I have a reason for every step of every part of the procedure. I know why that procedure is going to fit that patient best and where they are in that process. And I want the patient to be well informed. If someone is in and out of the visit room in 10 minutes or 15 minutes and doesn't take the time to answer your questions, I have a hard time with thinking that they're going to be caring for you in the same way as someone who's going to go through, sit down, look at your case very carefully, and make sure that you understand what's going on so that you know what you're getting into and what the results can be in a very consistent way, and also know that you're getting the right procedure, right? So I think that's critical. So the answer is, if they're not, then I would have a tough time recommending going with them.
I agree with that. I think that's already, a glimpse into what your experience will be like, right?
Mhm.
And I guess I wanted to add for our attendees tonight that, I think for looking into a therapist, who you'll have a good working relationship with, that's a little bit difficult too, because a lot of it depends, like, to be able to ask the questions that Jay had recommended, or even, what we had just discussed. There is like the frontline staff, the admin staff, who are very often protective of an influx of questions from the community. And there's often this culture, I want to say, where, you should just be lucky that you'll be going and, to our organization and getting treatment here. And you don't even get a chance to ask those questions. So, I think that might give you a glimpse to, again, your experience, but that's not always the case. I know that for a fact. And, so I think that the important thing is to, really advocate for yourself, be persistent, and say, you know what, this is a relationship that's going to be long-term, and I want to make sure that it's right from the start, because I don't want to have an evaluation and find out and discover after like a 4-month wait, and then discover that it's not the right fit. And so there are definitely some questions that you can ask just to get a sense of what it's like. And chemistry is always a big thing between any two people, right? But what you could probably ask even the admin staff, if you do have like that type of front line to navigate through, is, can you at least tell me if the clinic offers intensive therapy, which is defined by 5 times a week at the very least, because that will already kind of give you a sense. Because if they don't offer that, it is a place that is not necessarily going to give you that option, because a lot of patients need that for the active reduction phase. And so that's a general question, and that's going to give you a lot of insight to the clinic's culture and way of practicing.
Yeah, absolutely. And for us too, we really put a lot of effort in training our staff and having the people who answer the first phone, being able to answer those questions and guide someone to make sure that they're a fit for coming to our office. Most of our patients are out of state. They have to fly to come to us. And we really try and make sure that the patients are going to come, are going to be good candidates for the procedure. I don't want someone to visit if we know for sure it's not going to work. For example, if you're actively smoking, this isn't going to be the surgery for you. It's just not going to work until you quit, as an example. And I'd rather spare you the trip than have you come all the way and say, I can't even go past step 1 if I'm, say, actively smoking, as an example.
Yeah, that's great. Thank you so much for that. Okay, Jay, so we have 14 questions, and we're definitely going to go over. If we can have some more of your time, I'm okay with you guys. This will be recorded and be available to the community for a little while, but I think it's important. So the first question, I'm just going to go in order in which it was entered. So this is from Stephen. Dr. Granzow, at your presentation's conclusion, can you please relay the female-male ratio of your patients, plus the primary-secondary ratio, and a final ratio of straightforward extremity cases versus more complex cases? Thank you. Looking forward to the presentation. So this was like at the beginning of your presentation. He previously saw one of your talks. Great lymphatic health from Canada's capital, Lympho-GWG. Thank you, Stephen.
All right, fantastic. So to take those answers down, the first one is male to female. Female cases are vastly outnumber the male cases. So we're talking on the order of 20 to 1 or more. That's just the way that the presentations are. I think there are a lot more GYN. It's usually mostly because there are a lot more GYN cancers than there are male cancers that have the more invasive surgery or those more invasive procedures. The second part is how many, let me think if I remember right, the congenital versus secondary. I think the secondaries tend to outnumber the congenitals by about 5 to 1. So 1 or 2 out of 10 patients will be congenital, and the rest tend to be secondary. So maybe it's about 2 out of 10. So 4 out of 5 1 out of 5 are congenital. As far as very complicated versus not, well, That's a difficult question to answer, just because what I think is pretty easy tends to be complicated a lot, is what my staff always tell me. So, or at least straightforward for us. So straightforward for us is most of our patients, I'd say, but most of those patients themselves are complicated. So, yeah, I don't know if if that's the best way to go. We've been doing this so much that we have a pretty good idea of how we can take care of patients and what our expectations can be for the vast majority.
Thank you. Alyssa has two questions. How successful are surgeries in patients with primary lymphedema, such as Milroy's, when both legs are affected? She lives in a small town with no specialist. How many days? The second question is, how many days would be needed to schedule to go to, I guess, for a lymphedema surgery, for the first appointment consultation and follow-up visits, I guess. I'm not so sure if she's talking about therapy or surgery now, because she asked, yeah, so I don't know how you can answer.
I know how to answer that one. I think so for me, the SAPL surgery, if we're talking someone with advanced lymphedema, and typically something that's been going on a long time, tends to have solids involved. So assuming that it's a stage 2 lymphedema, we're performing SAPL surgery. The SAPL surgery will be equally effective on a patient with congenital lymphedema as secondary lymphedema. If there are two legs involved, the first leg, so say we have one leg involved, we can measure the opposite leg and use that as a template for the postoperative compression garment right away. That assumes you have a normal leg. So that, in that case, you typically come and for surgery be with us about a week. If you don't have a normal leg, meaning both legs are affected, we actually have to measure in the operating room, send those measurements to Germany. The custom compression garment gets made the next day, put on the plane and shipped out. With COVID, it's been a little bit slower. So you're going to be with us more like 10 to 12 days or even 14 to do that right. For the initial consult, patients tend to come and we tend to get imaging as well. So you'll tend to spend about a day and a half in our area. All said, in our office, it'll be about a half a day to spend with us, plus the imaging, which is done at a radiology center that we recommend. And so between both of those, say you come and you have a consultation with us on a Tuesday, you'd have the imaging on the Monday prior, and you could fly home that Tuesday afternoon or evening, typically. But it'll be a fair amount of time, because we really are very comprehensive in what we do. We have all the different team members go through with the patient, their condition as well as myself. And we invest a considerable amount of our time and effort into making sure that that patient is taken care of properly.
Thank you, Jay. We have a couple of questions in terms of the ability to treat certain regions of the body. Fenton asked about bilateral primary lower extremity, and there's another question about abdominal lymphedema. Karen asked if you treat abdominal lymphedema.
Got it. So one question on bilateral lower extremity. Yes, absolutely. We can take care of that. There are different protocols for bilateral than unilateral, but it's certainly something that we've seen many cases of. Abdominal lymphedema, I'm not as good at treating, meaning that we just don't have as much experience with it. That the legs and arms keep us absolutely busy right now. Again, we've had some shutdowns in the hospital due to COVID. We're now back doing surgeries, but we're booking out into August and September. So we tend not to have the abdominal issues. That's something where we can provide referrals for colleagues who might approach that.
Thank you. There are definitely a couple of questions in terms of getting in touch with you. So I believe that your team, Kat and Julie, are on the line. Kat and Julie, if you can just type into the chat how people can get in contact with the office, that would be greatly appreciated. And then there's another question in terms of how do you determine whether you use LVA or VLNT?
Right. So it's an excellent question. Both of those procedures are microsurgery and super microsurgery procedures that drain fluid. I tend to use them both together at around the same time or in the same set of surgeries, because I want the maximum result possible. When I first started doing these procedures, so LVA was the first procedure I did, and then I added VLNT, I tend to do them in separate patients because I wanted to really be sure for myself that, and we're talking, this is 2005, 6, 7, 8, somewhere in there. I wanted to make sure that those procedures really were functioning for those patients. And I found that they both work. What I found further is that if you combine them and do a VLNT and then some LVAs in the same patient, they actually work even better together. So I tend to do both if possible.
Thank you. The next several questions that I'm going to kind of lump together is the availability of surgeons in general. So one person asked if there are any good referrals for Europe. Another asked how many specialized lymphedema surgeons are there nationwide, and what would you recommend for a consult in New York City?
Yeah, so it depends on who the surgeon is and what your particular condition is. So as far as referrals, we have a lot of colleagues who are close, but it is still a very small community. And surgeons all approach lymphedema in very, very different ways. You'll find out, just like orthopedic surgeons might or cardiac surgeons might as well. Certainly, we've got friends such as Joe Diane in New York City who are fantastic individuals. In Europe, we would know, for example, Håkan Borsen is in Sweden, Alex Monach is in Scotland, as two people I know, Corinne Becker in Paris as well. Everyone has a different, Jaume Marcia is in Spain. And then in Belgium, we have other colleagues as well who would be able to take care of patients too. So everyone has their own different approach, and then it becomes very specific as to how they treat each different patient.
Thank you. And to that list, I'd like to add Alex Wing in Texas.
Yeah, they asked New York though.
Oh no, for sure. But because
yeah, Alex is great too. Yeah, absolutely.
Yeah. Okay.
And we have many more. That's just a very limited one. And
for sure.
If you called our office, we could probably give you the best referrals.
Yes, I felt the need just to include Alex because he spoke at our 2020 conference. So
sure, absolutely.
Just wanted to give him some love. Okay, so Ned is asking, is surgery for primary lymphedema more difficult than for secondary?
So for me, SAPL surgery is pretty similar. The VLNT and LVA surgery can be different. And that's why I perform a tremendous amount of imaging at the beginning of a VLNT surgery and also the LVA surgery. LVA surgery would be more variable in someone with congenital lymphedema because for a secondary patient, meaning that the patient had lymphedema after, say, cancer treatment, we assume that their lymphatic system is relatively normal beforehand, at least on the collector side or on the distal, meaning down on the foot or the hand side. For a congenital one, we don't know if the congenital lymphedema is caused because they have less vessels, the vessels are deformed, the muscle, they don't pump as well, they don't pump as often. There's something centrally that they're not draining to. So that system probably isn't as good to begin with. So the potential improvements you'd think are lower, but in my experience in many patients, their outcomes have been just as good or better than some of the secondary patients. So theoretically it'd be worse. I think practically, again, it's more variable, but the results can be equal or better.
Thank you. Carmela also wanted to add to the list Dr. Pedro Cuidad in Lima, Peru. Thank you, Carmela. Now, another question from Lynn is, have you had any patients with Parkes-Weber syndrome?
Parkes-Weber, so you're looking at something that's a lymphatic that tends to involve the other tissues. Those are going to be much harder to treat. And there you're going to want to go to a doctor who does like vascular malformations or lymphatic malformations.
Thank you, Jay. Another question in terms of body part region that you can potentially work on. Can you work on genital lymphedema, especially for male?
Yeah, so genital lymphedema, it depends on how that genital lymphedema presents, meaning is it early or late stage? If it's late stage, the equivalent of SAPL surgery there is going to be where the urologist would actually take out that diseased tissue and place skin grafts on it as a SAPL type of surgery, and that will actually bring things down quite well. If it's early enough, you can actually potentially perform LVAs, and that's going to be on a case-by-case basis.
Thank you. This is a little bit of a long question. What is the typical risk of developing blood clots post-surgery? This person had a very large calcified lymph mass removed just above the knee in the inner thigh. 3 weeks later, a massive blood clot to both lungs, or massive blood clots to both lungs, ended up in ICU, nursing home for 3 months, experiencing severe lymph issues now. Surgeons said unable to use blood thinners at the time because of the amount of blood vessels involved. Other doctors that she's talked with has disagreed. So in general, what is your experience with blood clots post-op?
Right. So blood clots are a danger regardless of what type of procedure you do. The longer the procedure, the more invasive the procedure, the higher chance. But it's something where every time you drive on the street, you can be in a car accident. It can happen. It's very infrequent, so usually much less than 1% risk, but it's there. And there's a whole risk stratification system, including something called a Caprini score. But basically, if you have a cancer, there are multiple risk factors that'll put you at higher risk for blood clots that can bring that risk up above that very, very, very low initial risk. And that's beyond the scope of our discussion here. And so that being said, we've just seen a couple. I think that, and again, any surgeon, if they've operated long enough, is going to have one in a patient somewhere, just because that's part of doing those procedures. But again, it's rare, and the treatments are pretty standardized. It sounded like this patient had a bad experience with that, and you are going to have patients who have bad experience. Fortunately, we've never had something even remotely to that extent. It'll be much more common in, say, big orthopedic injuries, traumas, large cancer resections. Here, if you have a big lymphatic issue resected, that's going to go on the larger range of surgery, and then just have maybe some bad luck thrown in, probably.
Well, that's a great question to ask you, actually, Jay, because I've come across in my discussions with therapists and other doctors and patients as well, where the first experience with surgery was not a positive one. If anything, that surgery made it much worse. So when those patients come to you, are you able to help them?
This is for lymphedema surgery has made it worse.
Yeah.
So that goes into the lecture itself, in the selection of therapists and the selection of surgeons. And so in the vast majority of cases, we can help that patient in a very significant, life-changing way. And that tends to be our expectation with our patients, and we can tend to achieve that whether or not they've had surgery. Having had previous surgery does tend to make things more complicated, and does often limit some of the options, because some of those maybe recipient sites have been taken, or if you've had a lymph node transfer somewhere, obviously I can't borrow from that area or put it into that area. There's going to be additional scarring involved, which will make the healing more difficult, or limit where I can access for, say, microsurgery. So bottom line is, typically, yes, we can help those patients in the vast majority of cases, but it may limit what overall can be done, because some of those areas have already been operated.
Thank you. An insurance question: does Medicare cover any of your surgeries under any circumstance?
Yeah, so Medicare has always been a tough one, and for us in our office, we've basically gotten coverage from essentially every insurance. Well, let me preface this by saying I'm really bad at insurance. I'm actually terrible at insurance, and I have a fantastic team of 5 individuals who are, almost all of them work full-time just on the insurance part. So I do the medical part, I'll send it over there, and then they really work closely with the patients to get those approved. And we've basically been able to work with, my understanding is, all the companies overwhelmingly to get coverage. Medicare is a tough one, and there we've kind of hit a wall with at least our practice and getting coverage. I think that does sound like it happens in some centers, but we've not been able to, we haven't been so successful with that one.
Thank you. Okay, I think I'm just gonna try to read this. Okay, Dr. Granzow, seeing photos of you with overseas colleagues, I ask whether or when lymphology might become a certified medical society in North America, USA and Canada, where currently we must rely on other medical specialists with interest in lymphatics and lymphology. When I compare ISL, ESL, WSL with LANA, the difference appears immense. In other words, clinical practitioner professional, CLT, MT, OT, etc., versus medical specialists, lymphologists. Thank you for including this information in your presentation.
That might be a good question for Jeanette, actually, here, because again, with for NLN and Learn, I think to just bring another one, but especially NLN, it's we have we have a we have a lot of great colleagues who are involved with those organizations. That the other organizations are organizations that we can belong to as well. They tend to be overseas based, and they'll have their strengths and weaknesses too. So how do I answer that? Otherwise, it's we tend to go to similar meetings. We might, as microsurgeons, go to say ASRM, which is a American Society of Reconstructive Microsurgery meeting. But certainly, I think that in America, the I mean, NLN has really brought people together more than anyone else as a real marketplace, not marketplace, but a real community to know that you're not alone with lymphedema. One thing, patients come and they get lymphedema and they feel like they're the only one that they've known who's ever had it, or even their doctor's ever known who's ever had it. And what do I do? And you find you have a community of people who care, who can connect you with people where you can get better care, you can get treatment. There are things you can do to get better, and not just a little better, but a lot better, and get through that process. So I don't know if that's the right answer, or the answer that they were meaning, but I think certainly we find that consistently.
Yeah, no, thank you, Jay, for your response. And to Stephen, who asked the question, you know, I actually agree with you. I think that there is so much work that remains to be achieved and done here in the US. And, you know, we're doing our part slowly. And, you know, I think that one of the biggest things that we need to do is to really, in the US, make lymphology like a specialty. And where does that start? That starts in the medical schools, right? And right now, as you might already know, medical schools spend, I mean, maybe 2 hours on lymphatic.
It's very frustrating. We went to local medical school here, and they said they just don't have time in the curriculum. It's super frustrating when you have how many hours, even in the first 2 years, to be able to allot 1 hour to get a basic overview, to just give physicians the idea that this is what lymphedema is and what resources do we have and how can we refer our patients, right? And they haven't been willing to do that. So it's at least in my experience. So I think it's something that the education is very important, and that's why we're doing seminars like this. And thank you for putting this on. Yeah,
well, thank you for being a part of it. But Stephen, you just wait and give us another year or two, and you will see what we've got in store. This year, it's the position papers. Next year, we'll start to work on bigger projects, but stay tuned. Okay, the next question is from Mary Ann, and I just need to make sure I understand this first. Okay, this is for you. Regarding footwear before surgery, she could not find shoes to wear. She lives in the north. She has looked and tried all over to get an extra wide color and style. Yes. Oh, wait, I lost the question. Wait, color and style at this point are unimportant. Perhaps you can email her privately about some important footwear that she can consider.
Yeah, footwear is going to be a question again. I think you're going to have a better input on that than I will, Jeanette. That's a question I'm going to tend to refer to Julie and Wendy, and then you guys at NLN as well.
Yeah, thank you. You know, we are going to have a session later on this month, Marriott, on walking and lymphedema, and I'm hoping to get a couple of sponsors that actually have footwear that they created especially for this purpose. So join us for that session, and if not, I'll at least present you know, a couple of the options. Okay, now this is from Billy, and it spans 3 separate sections. Let me see. Okay, how about ankle surgery? In terms of attaching the lateral side of the ankle soleus, can the edema channel here be worked with? Lymph vessels were injured. Do you get that?
Well, I think with specific patient questions, it's essentially impossible to answer if I'm on here. The specifics of each patient are extremely important, as well as the history. So when you come to us, that's why we spend a half a day and I wish I could answer it best over the video, especially now now people are able to travel with COVID again. So it's much better. Our area is finally starting to normalize too, or has essentially normalized. We've all gotten vaccines for a while now, which is good. But I can't answer the specific question. Just generally, we'll take the time to spend, you know, the therapist will spend a long time, my PA and therapist will, and then I'll spend the time to go over that specific situation. And we'll need do the imaging as you need to as well.
Thank you. 2 more questions and 1 more comment, which we will conclude with. This is from Leanna. What would be the average cost of performing this surgery? Performing lymph surgery on unilateral lower extremity on the lower limb only? What is the rate of success in such cases? And if anything goes wrong, can it potentially worsen the lymphedema?
Right. So as far as costs, again, I'm even worse on the costs than I am on the insurance side. But that being said, is my understanding is most patients are out of pocket very little because we can get the good reimbursement with the insurance companies work with them. It's always a process, but as far as the individual case, again, I'm unable to comment on that individual case. We do have patients that have focal areas that have had just lower leg, just foot, just upper leg. Yesterday, I had someone where the foot was spared, which is unusual. And it was mostly from about mid calf up to the lateral hip and flank, actually. And that was very different than the opposite side. So we'll be able to focus in on that condition that I feel pretty confident with. And then the insurance part, we would work with you as well.
Thank you, Jay. I know you pretty much just kind of answered this, but just in case there's a nuanced difference that you'd like to add to it, but how long is a typical lower extremity surgery for congenital primary lymphedema?
It all depends on the surgery and what surgery is required. So typically the SAPL surgery will take about 4 hours for that arm or leg. And then LV or VLNT surgery, I typically take the full 8 hours if we're doing a day for that, because you want me to get as many connections as possible. And I might even take multiple days to do that, because to get as many connections, my philosophy is the more connections, the better the drainage, the longer they're going to stay open, and the more that will stay open. And that's really borne out. And the way that I do LVAs has really evolved over the past 10 years as well, or even 15 years, so that just the results are really good. Yeah, I don't know if that answers the question, but.
Thank you. Elsinore would like to insist that you answer, can it get worse?
Oh, sorry. Can it get worse? Theoretically, lymphedema can get worse. I haven't had that. I can't recall a patient where that's happened. With a SAPL surgery, the way we do that, again, if you have compliance in the garment afterwards, 100% of our patients have gotten a lot better.
Thank you.
Dramatically. For LVAs, the chances of you getting worse, theoretically, you could be hit by a bus when you're driving on the freeway. But that being said, I've never heard of anyone even getting worse from LVA, and it hasn't happened with us. For VLNT surgery, we have seen some isolated reports of where people borrowed from donor sites and had issues at that donor site. So that's why I spend the incredible amount of time with imaging, both before surgery and during the surgery, to minimize those risks. And so we haven't had those issues either. So yes, it can get worse, just like in pretty much any surgery, your outcome could theoretically get worse, but the chances are really low.
Thank you so much. There was one more question that slid in, and I figured we have 3 more minutes, so let's just do it. Get all of the questions in. Would surgery be warranted for infections on a breast cancer survivor with lymphedema who manages it well? Because now she has monthly infections about 6 times with 5 years since cancer.
Right. So for us, one of the greatest improvements that we see is that reduction in infections. I mean, we can typically dramatically drop the amount of infections we have in our patients. And that was that one example that we had of that patient with breast cancer, 19 years history, where I put it in there, and she had daily antibiotics to prevent those infections from coming up. Now, how that would work, how much that risk reduction would be expected, that all is very specific to each patient, and we'd have to go over that in detail. But typically, that reduction in infections is one of the absolute greatest improvements that we achieve.
Thank you. That is all of the questions. And the last comment is, can you please provide brochures to this lymphedema clinic? This is from Oscar and Anna, and they said, great presentation. And with that, I would like to say, I definitely agree. Thank you so much for this amazing presentation. It was very informative. I think that anybody who's on right now and who will be watching the recording will definitely have a clear understanding. And I think that whenever you have a deeper understanding of anything, you can make a better informed decision for yourself. So Jay, thank you so much.
Thanks very much.
Yeah. All right. And so we're going to end with our drawing. I think there were only 3 raised hands. And so Alyssa, I believe you entered it into the wheel. And so if you can please go ahead and share your screen so that you can actually spin it and everybody can actually see it.
Okay, Jeanette, I totally dropped the ball on the wheel.
Oh, okay. Then you know what? We're just going to ask Jay. Jay, can you come back on? And we're going to ask you to pick a name, a random name. If you go ahead.
I'll just give you, pick the second out of the 3. How's that? I can't even see them from here.
Oh, okay. We're just going to pick the second name.
Number 2.
Got it. The second name is Monica Stelter. And she's a therapist and a very good one. And Monica, congratulations on winning either a Prima or a Vita compression bra for one of your patients. And if you can just email Christy, it's christy.blair@lymphnet.org, and she will get you connected to Prairie Wear. We'd like to thank Rocky for donating the bra to us and for his sponsorship of our webinar series. We would also like to thank Dr. Granzow, who also sponsored our webinar series as well. So Jay, thank you for not only sharing your expertise, but for your consistent support in terms of time and energy and resources. And thank you to each and every single one of you who stayed on to the very end. We hope that you had a wonderful experience with today's educational webinar, and we wish you good night. And we'll see you tomorrow for those of you who will be joining us tomorrow. Bye now.